everybody's ready to do. Alright, so let me just show you how, how I always put stuff up on the board and tell you how things are going. Put your reading up. You only have 2 assignments that are for the lab this semester, or this unit. One of them's pre-op. Same thing like with respiratory. It goes through the whole case study. You can either email me your answers like you did last time, or give me a hard copy. I don't care. The only thing, your other one is guiding your patient, I think it's safely through surgery. I think I forgot that. Anyway, I want you to do 10 multiple choice questions with that, and I need to see some critical thinking, okay? This information is going to help you with this unit. This is not busy work. This is excellent, excellent articles. So I want you to think about stuff. One of the biggest things that boards test on is malignant hyperthermia, and we're going to go over that more. And this really does sort of break it down for you. It's a little bit easy to read. The only thing I'm asking is when you email these assignments to me, you'll put them together. Makes it a little bit easier for me to, put the answers to the one, and then your 10 questions, you're going to put them on the same document and send it to me that way. Okay? That will be a great help. I have put up the PowerPoint, and I know you haven't had an opportunity to print it off and all that kind of good stuff, so if you just listen to me today. I've also, how like those little funny handouts, I've put a bunch of those up there for pre-op, and so those are pretty good. There's assignments. They're due on March the 3rd. I probably could change that just a little bit if I need to. Since your test. When's your test? Monday. So that will be what day? So that you'll have time. You'll have time. So I'm not going to change that. I'm not going to give you the answers either. I did put 2 articles up here. Like I said, they're good articles, but they're optional. I will not be testing from those articles, but they are pretty good articles. So that is everything that's due for me on this unit. I know all of you have heard about the wonderful experiences that we're having in the OR, seeing things that are crazy. So, but I want to make sure that and you can ask anybody who's been in the OR, once you get in there, you're so fascinated about what all is going on. Sometimes we forget to look at the reason why we're there. And the reason why we're there is to look at the roles of the nurses in the different areas in the operative unit. There is a pre-operative area. Most of us don't get a good opportunity to actually go into the pre-op area due to the fact of us getting there late and that kind of stuff. So we're not seeing a lot of pre-op in the hospital, but we're going to talk about what happens during pre-op, because pre-op is a major part of surgery. Then you have the intraoperative area. That's when your patient actually goes into the OR, and you see the different types of people that are in there, and you're looking at their roles as a nurse. Then you have a post-op area. So after the surgery is over, you go and see the person recover after their surgery. So there's 3 different areas that you're looking at when you look at the whole OR rotation. State Board of Nursing looks at those 3 areas. So it does break it down to pre-op, it does break it down to intra-op, and it does break it down to post-op. Out of those 3 different areas, the ones that you're not so much going to be tested on at board level is going to be your intra-op, because that is a specialty area. So the questions that are asked about the intra-op area is more of a, what is the responsibilities of these nurses in here? It's not going to be, It does ask some questions, and I'll ask some questions about things that you look for in that area, but it's nurse related, okay, and nursing care. The biggest part that you're going to be looking at on boards and looking in clinical is the post-op. How many of you have taken care of post-op patients? Lots. Lots and lots. And those are the type of people that you're going to see the most commonly that we're going to take care of. So that's going to be the one that's going to have the biggest information there. I do want to, before we get started, I'm going to ask Nathan. I've already asked him. Yesterday, we were able to see something extraordinary, like we always do. But I was going to let Nathan tell about his patient, and then I'm going to pass the pictures around and you can see. So what was going on with your little man yesterday?
He was getting a colon removed, and it was cool because we were able to see the surgery, how it started. The surgeon cut quite a few incisions in the abdomen, stuck a camera in there, and he had his little tools that he was snipping away. Then he cut a little bit bigger of an incision to fit his hand in. But once he started realizing how big the colon actually was, because he was only wanting to remove about 3/4 of it, he knew that he had to cut the whole abdomen open. So then he was like, no, we have to change this to open. So they slid it all the way open, and he started, he did his thing, and he started whipping it out, and it was huge.
Did his thing and whipped it out. Not so sure if that's appropriate terminology. Okay, otherwise.
Well, I don't know how much the picture does justice, but it was big.
It's getting deeper and deeper.
That wasn't any better.
It's getting deeper and deeper. First of all, how big is the colon usually? Not long, but how big?
It's probably like that.
Yeah. How big was his?
It was more like that.
Wow. Yeah.
Like the whole thing. It wasn't like just a piece of it. It was like
this long.
It was amazing. But the thing that got me is the patient was asymptomatic.
Yeah, he said that he didn't really complain of any symptoms at all. I don't even know what brought him to the hospital. His abdomen was really distended. It was nice. It was cool to see, like, when it was completely done and taken out, how his abdomen just like sat so flat again and everything.
So the patient wasn't really hurting. Once you see this bowel, you're gonna wonder why. So I'm going to pass the bowel around and let y'all see that. It doesn't do it justice. Like I said, it was like this big. But the really crazy thing is that it was full of air. I thought that it would have been full of stool, even though he had a prep, but it was just completely. And I think he said he didn't really have an obstruction. He just had a stricture. So it was like it was down at the bottom. And so it was like making everything back up, and it was more air than anything. So it was very interesting. But the moral of the story, yes, I want you to see a big bowel, but the moral of the story is we sometimes miss stuff when we assess our patients because a patient doesn't have any signs and symptoms. The only thing I think that I heard someone say was he had noticed his abdomen was distended. And it looked like he was getting, like he felt like he was pregnant. And that was the only thing that, so there's sometimes that we assess patients or we talk to patients and they don't have signs and symptoms of what's going on. So sometimes we might miss stuff. So this surgeon wasn't expecting that. And when he went in and found that, that was pretty impressive. But anyway, did you have questions?
I want to know what the diagnosis was.
Yeah, I mean, it was just like no symptoms and just a little bit of not really an occlusion. I mean, I would have liked to have assessed him prior to and been able to talk to him and say, what brought you here? Listen to his abdomen to see if he had bowel sounds and just to see what was, but of course we were able to do that, but I thought it was pretty interesting that we were able to see those kind of things. So I passed that around for you so you can look at that. And let's go ahead and get started in our pre-operative or the surgery part. obviously everybody knows what surgery is. We have such a responsibility as nurses when our patients are faced with surgery. I think one of the biggest things that I hear every one of the students since I've been taking people to OR, the biggest thing that they see is this is a team work involvement or this patient. This is, if you're ever going to see teamwork, this is when you're going to see it. Because there's so many different phases that the patient has to go through to get to the point of going to surgery, that we've got to take advantage of that pre-operative or the beginning of it to make sure that they're educated. You've got surgeons in there. You've got, and I don't know if some of you even got to realize that there's actually a pharmacist right there in the OR setting, so they don't have to wait and go and run to the pharmacist to get medication. They have one right there online, right there on site, so we can go get whatever meds we need. Dietitians come in post-operatively. All types of people, like physical therapy. You know, we're all going to be working together throughout this thing. The biggest thing that you're going to see when you are in the preoperative thing is a nurse, well, look at that, is we have got to be advocates for our patients. If you're ever going to be an advocate, preoperatively is going to be the major part that you're going to see. What do you think the biggest part in pre-op is other than advocacy? Teaching. Exactly. Because so much has to be done preoperatively before they ever get into the OR. I.e., what is the first thing that patients feel when they're told they're going to surgery? They're scared. Their biggest thing. So guys, this is a time that psychosocial is pretty important. Not saying, I mean, I want you to realize that I know when I have to go to surgery, I am so scared. You know, and our patients are scared too. They're scared of not waking up. They're scared that whatever they find in there, like patients going in not knowing what is actually in there. We had a patient last week that had, I think he was a bowel too. Started out with a bowel. Then when they opened him up, he had bladder cancer as well. So the fear of not knowing what they're going to find when they get in there adds to our stress. And the fear of the unknown. If they have never been to surgery before, they don't know what to anticipate, they don't know what's going on, it is a major. So I want you to understand that you're going to have to look in the preoperative time. Yes, I'm telling you teaching is important, but you're going to have to assess that patient to see if they're ready for that teaching. And I think that's one of the biggest things I told you when we started teaching our patients. You got to make sure they're ready. If they just got the diagnosis of, oh, this may be cancer, that is not going to be the time that we need to be in their face telling them how to turn, cough, and deep breathe. Okay? Because that is not their focus right now. So you've got to learn, you've got to be in tune to what the patient's feeling at that point to make sure is teaching a good time. Ideally, yes, preoperative, let's get all the teaching we can get done. Because if we teach them prior to, we're not going to have, we can just reinforce it later. Okay? So we try to teach as much as we can during the preoperative time. There are different types, and I don't like to spend a lot of time on definitions. You can read definitions, but there's a lot of different reasons why we do surgery. This is not just something we want to go up and say, no, I'd like to have surgery. You know, I want my colon removed. You know, the only time we really try to, or when we do that, is cosmetic. And I've listed all the ones and given you an example, and I'll get to cosmetic in just a minute. Diagnostic. Those are different types of things that you do in surgery to see if something's wrong. one of the major things that you're going to see as far as surgery are biopsies. As far as diagnostic, patients are going to go in and you can see the process. They go have a mammogram. The mammogram comes, shows a spot. What do they do next? Biopsy it. So that is a part of surgery that they actually go in, and that's pretty devastating to go through that. Although they're not going to be, on the table for 20 hours, it is still a part of being put to sleep and biopsying and not knowing what's going to be the result. Curative, those are ones that, and we saw quite a few appendectomies this week. Do we need our appendix? No. But what usually happens for curative is if my patient's appendix gets inflamed or if my patient's gallbladder gets inflamed, the best thing I need to do is get it out, right? Mm-hmm. Just get it out. Are they cured?
Well, yeah, it's gone.
Because what the problem is the gallbladder. Once we get it out, they're cured. Okay? If they've got someone who's got a diabetic foot that needs to be amputated, that's pretty much cured. Once I get it amputated, does it mean that it's going to come back? It probably will. Especially if it's already had decreased tissue perfusion. But that foot, it's in there, it's done, and we're ready to move on. Okay? Other types of things, types of surgeries, cosmetics. I know all of y'all love to talk about breast implants, but that is one of the most common ones. Now, I will tell you, this week we had the first surgery that's ever been done at Northeast was done yesterday, and it's called a tram. And what it was is the patient had breast cancer, and they were coming in for reconstruction, and they actually cut here and bring the fat here and make her breast. So she gets a tummy tuck and a breast augmentation all in one. But that was the first time that they have ever done that procedure at Northeast, so we were involved in that. One of the best things that happened, they had already told us at the beginning of the day that no, we could not go in. I was like, dang it! So of course, me and Alicia's going, come on, let's go, let's walk over there. So we went walking over there and pulled the window up, and we were just looking. Well, then here comes the surgeon. And I was like, okay, let's see if I can turn my charm on. I was like, hey, I'm Leanne Walker, one of the nursing instructors from Run Embarrassed. This is Alicia. She's one of the students. He was like, come on in. I was like, yes. And so Alicia got to go on in, and then later he was like, bring them all in. Bring them all in.
Yeah, cool.
So they all got to go in and see this first surgery, and it was very meticulous. It was very long surgery, but they were able to see that. At that point in time, I was not worried about them looking at the roles of the nurses, to be honest, because this was like, oh my gosh, we are part of history here. We're going to be a part of this, and we're going to see something that's pretty amazing. So he always wanted them to look at the nurses, but it was a very tedious, very intense surgery. So anyway, that's one cosmetic wise. Palliative, those are ones that your patient has colon cancer, and we know that he has colon cancer. Let's get the cancer out, but it may not be that his cancer is completely gone, so we're going to have to do something else because the colon's not going to work anymore, so we're going to have to do another thing to help him have bowel movements, and that's a colostomy. So palliative, sometimes you think, oh, we're not doing anything for palliative. There are things that you can do to help make the patient comfortable, because we all got to poop. Okay, we all got to do that. So whether it's pooping through a bag or pooping the other way, we got to make sure that there's another thing that's going to relieve some of the symptoms from this disease process. So palliative's another one. Remember, palliative's not a cure. Construction, that's like a knee replacement. Those of you got to see, there were several of you got to see lots of knee replacements. meaning that some part of our body is worn out. And I think the one of the orthopedic that Jeff got to see, that patient had tore everything in her knee. I mean, everything. The ACL, the MCL, everything. So they had to construct a whole knee, basically, so that patient would be ambulatory. Transplant. Unfortunately, we are not one that gets to see transplants when we go at Northeast. I eventually think it may happen, but right now it does not happen. But this is when our organs die, or the patient's going to die, and they cannot live without having that organ. So when unfortunately, someone else has to pass away, so we can use those organs. If you're not an organ donor, I would encourage you to be an organ donor. Ashton had a friend that had a car wreck when he, like 2 weeks after he graduated from high school. And he had just went and made for him to be an organ donor, like just a couple weeks before he died. And when he died, he was able to give someone a cornea, a heart, and there were two other things that I can't remember right off the hand. I mean, the kid's 18 years old. And you hate to see one person die, but at least you know one person, we're going to help somebody else. So they actually kept him alive, and that's what they do. They put him on ventilators. They keep him alive until they find the match and who it can belong to. And as soon as they, make that decision that they can donate, they get that organ and they take it to where they need to. It's pretty intense. But you will see those type of surgeries, not at Northeast. You can have an elective surgery, an urgent surgery, or emergent surgery. Elective is just something I want to go have done. Okay? It's not life-threatening, but it's chosen that I know that I can't see because of these cataracts, and then the patient just decides when they want to do it. So it's not a life-threatening situation. It's just they say, okay, most of the time they'll say, you know what, I'm tired of not seeing. I'm going to go get this cataract off. So it's not something that's going to be life-threatening. Now that I said that, any time we put a patient under, there is a risk. Okay, so don't think that I'm making light of the different types or urgencies of surgeries or the purposes. Anytime we put anybody under anesthesia, there's risk. Okay, so what this is meaning is, when do I need to do it? How fast do I need to have this done? A cataract surgery is not an emergency. You have an emergent means that I have got to do something within 24 to 48 hours. If I don't jump on it within that time frame, that patient's going to possibly turn into an emergent situation. So I've got a little bit of time, but I don't have a lot of time. Okay, so I've got 24 hours. But you will see this most commonly when our little old ladies or gentlemen fall and they break a hip. Yes, they're going to take them to the hospital. The reason why I'm not taking them straight in surgery would be why.
If they're not stable.
I got to get them stabilized. I also got to look at what their history. What is the major organ I got to make sure is working? I got to make sure that heart's working good. I do not want to take somebody into an urgent surgery until I make sure that their heart can withstand what's going on. So that's why we've got that time frame of about 24 to 48 hours, because the first thing you'll say is, oh my gosh, she's hurting, she's got a broke hip. Yeah, she's hurting, we can keep her comfortable, but if her heart's not working right, what do you think is going to happen when we put her on the table? She's going to die. And I don't want her to die. I'd rather wait that 24 to 48 hours to make sure that she can handle this. So that's the kind of situations that you see that are urgent. Emergency, I mean, I got to go. I was talking to one of the CRNAs the other day, and I hate to even tell the group that was supposed to be there on that Wednesday that it snowed, but they had the gunshot wounds come in. I know, Teresa, you. But they had 3 gunshot wounds come in at the same time. That's an emergency situation.
Yeah.
As I was talking to the CRNA, of course, they were not successful in saving their lives. But they were in the OR, the emergency room, and they came straight up and went to surgery, and they worked and they worked and they worked and they worked, and they were not able to. I know that the one CRNA told me they had given the patient 30 units of blood. 30. Yeah, and as fast as it was going in, it was also coming out. So that's the one that I need to see, and I need to go get something done now. One of the most common things that you're going to see as far as emergency, yes, gunshot wounds is going to be one. But since this summer, you're going to be talking about OB, and I know that's going to be a wonderful time for all you guys. I actually took Tyler with me around the OB unit yesterday, and you could see the uncomfortable feeling that was happening as we're walking through the OB department. So I know it's going to be very trying for you guys, but we'll get through it. But one of the biggest emergencies that you see with are the OBs, and what happens is that uterus ruptures. The rate of saving a baby in a mama after that uterus is ruptured is about what percent? Or let me just say, what are the chances of a baby in mama living? So the mortality rate's about 99.9%. Sometimes that happens with VBAC, and sometimes it just happens. You see it with multiple pregnancies. People that've been pregnant multiple, and have 6 babies, and it happens because the uterus is like a rubber band, and you stretch it and stretch it and stretch it and stretch it, and eventually it's gonna pop. So, and that's a major, major emergency. The bad thing about having that is sometimes you just don't know that it's getting ready to happen. The good thing, and I think we were talking, whoever was over on OB, they were like, why do you have a OR in the OB department? Yeah, it's right there. So we used to, a long time ago, have to rush our mamas all the way to another part of the hospital that was having this abruption or having whatever. And what do you think our rates were saving both of them? Not good at all. So now they realize that, hey, it might be a good idea if we put ORs right there on the OB. So the rooms are right here, and I can go straight in there and do what I can. And the rates are getting better. So emergency, I got to get in there and do it, because if I don't, my patients are going to die. You can have a minor, and just like I said a while ago, anytime we do surgery, there are risks. So I don't want you to think that there's no risk with a minor surgery. There's not a high risk, but that is significantly low with a minor surgery. Major surgery, what happens with those is anytime you see a major surgery, you're going to see a lot of blood, or you have at risk for blood. Those of you that have been in the OR, what do you see them doing when they do surgery, or keeping up with, or how is it set up? How do I know how much blood they're losing? I guess we'll stop asking. They have a little suction canister, and they actually put the end of the suction in the abdominal cavity, or wherever it is you're operating on, and it sucks out. So don't you think one of the biggest things when you go into the OR that you're going to be looking for is I want to see how much blood this patient's losing. Okay, so that's a big responsibility of a nurse in the OR. How much blood is that patient? Once they start messing with vital organs, then that's going to put their post-op complications at a higher risk. So let's say if we've got something going on with the lung, taking half of the lung out, because you can live without some of your lung, how do you think the post-op complications are going to be for that patient? That's gonna be, are we going to be on that patient like flies on poo-poo? Yes. I mean, because I know for a fact that vital organ, he's got to have that lung to breathe. So I'm going to anticipate that he's going to possibly have some post-op complications. So I'm going to be on him. So I'm going to be having him turn cough and breathe. I'm going to have insim spirometer. I walked in. My daughter's father-in-law to be had back surgery the other day, and of course, you know, Miss Walker walking in, and he's over here, and his heart rate's out the wazoo, and he's in pain, and da-da-da-da-da, you know, everything with post-op, and I'm like, here's your insim spirometer. You need to do this. And my daughter looked at me and said, Mama! I was like, I don't care. He needs to do this. Take a deep breath. We need to do this. And they're like, and he's like, but I did it a while ago. I don't care. Do it again. So, of course, he hadn't got pneumonia, which is a good thing. But anyway, so we know that what type of surgery they've had, whatever organ is, I know how, that's why I want you to understand the pathophysiology of the organs, so you'll know what happens and what I need to do to make sure that patient gets better through their surgery. Inpatient and outpatient surgery units. Of course, everybody that we're going to be observing their surgery is going to be inpatient. So what's going to happen is they're going to go to surgery, they're going to go to post-op, and then they're going to be taken up to a floor and they're going to be monitored more. They're not just going to ship them out the door. The other thing that you see a lot, and people are going to outpatient surgery centers more frequently. I actually had my breast reduction done outpatient. I don't remember a thing when I left that floor. Or I left and my husband put me in the car. I don't remember nothing. I mean, I was out. What the moral of the story is, you know, I always have a moral, is there's criteria that you've got to meet when you discharge a patient for outpatient surgery. The thing with the inpatient is when I report off to that nurse, I know somebody's coming right in to care for him. So I know he's going to be cared for. In our outpatient situations, I don't know who this patient's going home with. You know, it might be a significant other. It might be, you know, I need to know if my patient that I'm sending out the door with this person understands how to take care of them. So we try to make sure that when patients are in an outpatient situation, that there's several things, criteria that they have to meet prior to me sending them out the door. One of the first things is I got to make sure that their vital signs are stable. I don't want to send somebody out with a heart rate of 150. That is not stable. That is your responsibility to make sure in that setting that those vital signs are stable. You need to make sure that they're alert and oriented. Make sure that they know where they are. I had no idea where I was. You want to make sure that their pain is controlled. You want them to wake up good, talk to you, be able to assess what's going on. You want to make sure that they're understanding their discharge instructions. Now, when should you have been over your discharge instructions? In the pre-op time, right? Because they hadn't had drugs. Okay, and they're in their right mind, although they're a little bit nervous. It's a time that we need to make sure that their teaching's doing. Don't we need to include someone with them? Because they cannot drive home after they've had anesthesia. So they've got to have somebody with them. So I always include them in this is what I want you to do. Okay, here's the list. They need to turn, cough, and deep breathe. You need to make sure that their pain medicines, get a chart. This is when the pain medicines, if I'm going to give him something for pain before he goes home, don't you think I'm going to give the family member or significant other, this is what I gave him, this is how much I gave him, and this is what time I gave it to him. So they know when they go home, if they've got a prescription that says every 4 to 6 hours, they're going to count it from the time that I gave it to them. So they're going to have an idea. I got to have somebody with them. The other thing is I got to make sure that they pee. Because what happens when you're put to sleep, everything gets awful lazy. And one of the biggest things, especially if they had a catheter during the surgery, and we took it out after the surgery, how quickly do you think that meatus and that sphincter is going to get lazy? Very, very quickly. So I need to make sure that they can pee before I go home. My best friend, she's had multiple surgeries. Every time she's had an outpatient surgery, she has to go home with a catheter because she cannot pee. It is like pee shyness. I'm like, girl, go in there and pee. And she can't, so she has to go. And I don't want to have my patient going home with a follow because then I'm going to put them at risk for infection. So I got to give them pee-peeing. Get them up. Give them a little bit. Don't give them a big something to drink. And we'll talk about that later. But give them a little bit of water. Get them walking. Get them something. Sit them on the pot. Run water in there. Put water on their thighs. Something to get them to pee-pee. So make sure that they pee before you send them home. They need to be able to walk without falling. I don't know how I walked from my bed to the outside and got in the car. Don't know. But when I first went in there, he was like, did you take your Valium? I was like, no, I'm fine. I don't need no Valium. So I get on the table and I'm like, where's that Valium? I need a Valium now. And I had one after I had to get out of surgery too. So just make sure that they can walk and they have met that criteria. If you work in an outpatient setting, you will have a checklist and it will go through and say, are they alert and oriented? Then you may say you can check it. Have they voided? Yes. Those kind of things. You got to make sure. But this vital signs will bite you in the behind if your patient's not stable. I've seen nurses say, oh, they've met all the other criteria. Their heart rate's up just a little bit. We'll go ahead and let them go. I need to make sure that heart rate and those vital signs are stable before I sign off for letting them go home. Oh, did we ever get this whole thing to work? Somebody found it. Yay! Now I don't have to keep walking back over here. All right, let's see if it works. Which one? The bigger one. Oh, is that mobile? Okay, how to do that? Oh, yeah. Okay. All right. Do y'all need to take about a 2-minute break? Yes. And then we'll do pre-op. If anybody needs to go to the potty, they can go. I can keep going. I don't care. You don't have a problem with all this to me. Wow. Take those things in charge. One of the biggest things that we do is teach, and that we are advocates for them, and we are promoters of health. So that is one of the biggest things that you will see as a pre-op nurse. When I'm talking about that pre-op period, it begins when the client is scheduled for surgery. So they're gonna be in the surgeon's office. He's gonna say, yes, we're gonna have surgery. The teaching starts right then. These are more, I think all of our patients that are admitted to the hospital, we know that we've got to start discharge planning as soon as they're admitted, right? We start because we want them to get better and we want to help them meet their goals and get them out of here and be better. As soon as we start saying that we've got this surgery, we need to start teaching now. And we'll talk more about what needs to be taught to them in a little bit. But we're going to say that the patients during the pre-op time, they've talked about having surgery, and then we got to start integrating all of our education, and then we start integrating things that are going to affect the surgery. And as we look at the things that may affect the surgery that they're having, and we'll go through that in just a minute, we adjust our teaching and what type of surgery they've had, what kind of health problems they have, all to this education. So it's tailored to them. This is an individual plan of care for the patient going for surgery. Okay? Now, everybody that has a total hip replacement is going to have basically the same type of education that we need to go over, right? As far as how we need to position them, how they need to go to read, the exercises they do. But you also have to take into consideration other things that are happening with that patient when you're talking about education. Some of the things that may put this patient in different categories to help me know how to adjust is age. Age is one of the biggest things that we know that as they're going through this surgery that is going to affect their recovery, i.e. my elderly patients. Those are the ones that are usually going to go in with their hips. So we know that we've got to adjust our teaching because they're elderly, and we'll break it down in just a minute. Our very young, our infants, our toddlers, when they go to surgery, we've got to adjust a lot of that for them as well. We've got to make sure that we decrease all the stresses that we can of the surgery. We want to make sure, and we've already talked about the fear factor that goes into when they're going into surgery, so we know that we've got to address that too. Let me talk first about my infants. We got to see, I think, a 3-year-old. That's the youngest we've seen so far. Who went in on the 3-year-old? Alicia. Yeah, he was okay. We didn't get to see him pre-operatively, and we'll talk about a toddler in just a minute. But let me go back to my infants before I get ahead of myself. Infants. One of the biggest things that you see with my infants is they don't have good fluid volume. And what happens with them is as they lose, or should I say they don't have good fluid reserve. They have the volume is smaller, so the least little bit of fluid that they lose from surgery is going to put them at a higher risk for decreased perfusion and increased fluid deficit, as opposed to my patient who loses, an older patient, they can jump back quick when it comes to fluid volumes. My babies can't. We have to be very, very careful. Every little drop of blood that they lose is important as far as documentation, because they don't have that reserve to pop back. You know they can lose a lot, but we also have to be careful doing what? Giving them too much, because they can't control it. They cannot. So it is vital with my newborns and my infants when they're going into surgery, every little drop of blood that they lose is vital that I monitor and make sure that that they're PPing good and getting that fluid a little bit more stabilized. Another thing that you're going to see that is very, very important is newborns and infants cannot keep their temp up. They have a very difficult time maintaining their temperature when they're in an environment of stress. Why do you think we put caps on our newborns when they're born? Where do they lose their heat from? In their head. So if I keep it covered, then that's helping keep that temperature and help them maintain their temp. When you go to OB this summer, you may see some babies' temps as low as 96. And that's very, very concerning for a newborn. Because if their temperature drops, what else happens? Heart rate goes up. So heart rate goes down,
Blood pressure.
respirations go up, and so they have more trouble breathing. They go into respiratory acidosis. Okay, so they can't. That temperature has a major portion or important part in keeping that body functioning going on. When they go to surgery, and we'll talk more about this as far as the temperature in the rooms, it's generally cold, isn't it? For my babies, what do you think it's going to be?
Hot.
It's going to be hot. It's going to be very, very, and it's very hot up on Pete's. I thought I was going to have a stroke yesterday when I walked up there. I had sweat coming every which way. I was like, I got to get out of here. I'm hot. But we've got to keep that temperature up. So pediatric rooms, and if you go to pediatric rooms in surgery, you need to be anticipating that it's going to be very hot in there, because it is not about you. It's about making sure that their temperature is maintained, and they will be keeping an eye, a continuous eye, on that temperature throughout their surgery, because they know if that temp bottoms down, then that's going to put them at higher risk for respiratory problems and cardiac problems. They have a little thing that you can put under it. It's a little heating pad that they put. But they also have, and they do this on every patient because it is so cold in there, it's called a bear hug. And it's pretty neat. It's a little tray like thing, and it goes over the patients, and then they hook a heater to it, and it blows up, and it blows the hot air in there. So they definitely use those for pediatric patients. They use them for all patients, because not because adults get in trouble with hypothermia. Babies do, but patients get cold in the OR. So that's a really neat kind of thing, that little bear hug, and just put it all over you, and you just get all warm. And I also take care of your temperature when you're in the OR, don't I, Nathan?
What was that?
Don't I take care of your temperature when you're in the OR?
Oh, yeah, you do that. Such a nice mother.
I know, I'm not gonna handle, because I'll go in there, and Nathan's going, I'm not cold.
I wasn't cold at all.
I'm not cold. No, the other little student was cold, so of course I had to go get a warm blanket and wrap them up. Let Mother Walker take care of you, please. So, but my babies are so important. Please keep my babies warm. And it's just like, that's the mother in me. I work in labor and delivery, so when y'all are in there cold, I've got to mother y'all too. But know that they cannot keep their temperature up. The other thing that happens is once we give them drugs, where do drugs go? To the liver. Can they metabolize and break down that medication? So isn't their dosage very minute? And what do I base the calculation on? Weight. Exactly. So that weight is vital. We've got to know exactly how much they weigh, and make sure that we know that the dosage range, this is going to be a time, and I guess those of you that have been to pediatrics, you have seen when you look up the drugs you're giving your pediatric patients, you are looking at their weight, and you are calculating their weight to make sure that that dosage is within their range. Sometimes we think age. That's one of the first things that I used to think, well, how old are they? It doesn't matter how old they are, does it?
No.
Because some of our over-the-counter stuff says give between 6 and 12. You give this much. And as I've been a nurse, I always think, how much do you weigh? My little nephew, great nephew, is 7 years old, but he weighs 43 pounds. Very little. You know, he's very short, he's very, very little. So I'm more concerned about the weight of them to make sure. I don't care how old they are. And this is what I was talking about with this little toddler. I would have liked to see him pre-operatively, because he probably was just fine, because he may not have understood exactly what was going on. But one of the biggest things that you see with toddlers is they want their mamas. And they are so afraid that I'm not going to see my mama. I'm being separated. So they're going to be very clingy to mama, and that's going to be more heartbreaking as well when you have to actually drag that baby away from their mama and take them and put them in that situation. They're scared. So know that they may do fine during the surgery, but they're so scared because they want their mama. So when you're faced with a toddler in a pre-op area, this is the time you need to be a kid again. You need to play. You need to cut up. You need to play hide and seek. You need to do whatever you can to help that child feel comfortable and develop a relationship with you. So when you take him off, you know, and you'll see some of you that went back in the pre-op, I'm not sure if everybody got to see it. They have wagons back there, and they put them in wagons and give them stuffed animals, and they make a big deal about stuffed animals, and they do all kinds of crazy stuff. There's one girl that puts a paper on top of the sheet, and she draws crazy pictures with them, and you know, get them coloring, doing whatever we can do to get their mind off of what's getting ready to happen to them. The other thing is that they're afraid that they may die, they may never see their mama, or their body parts might be distorted. Now, our little 3-year-old had an undescended testicle. If we would have seen him before,
I saw him before.
oh, you got to see him?
No, because I was lost, remember?
Oh, you were lost? Imagine that, Alicia is lost. Did you see him, Hyson? So did you get to play with him or anything? Oh, okay, so was he scared? Good. Good. And I don't know if he even knew that they were going to be messing down there. Good. Good. So obviously somebody in pre-op did their job, and they did a good job of decreasing his anxiety and making him comfortable and not afraid. Because I think one of the biggest things that bothers me in nursing is to see patients scared. And I feel like I can't do anything about it. And I think that just bothers me more, especially with kids. I want to make sure that they're not scared. So I'm glad he was not scared. Love it. I can't believe I went back there playing with him. Y'all ever want to find me, I'm usually playing with the baby. Did you see the catheter in him? It's a feeding tube. It's just a little tiny, it was like a little tiny feeding tube.
We even had cartoons on the carts where they had instruments. Like, and they had, I think it was braid, I'm not sure, inside there.
Oh, you mean when they brought in all the instruments, they had like, instead of it being a silver, plain, dull-looking tray, it had animals and stuff.
How cool.
And I
Love
saw
that.
when they were wheeling him in the operating room, and he was calm. He was the nurse. And as I was walking, trying to find where I was at, I saw he was very calm.
Good, good. So, I mean, that's reassuring to me to know that if I had a 3-year-old that they're doing what they're supposed to be doing to make sure that baby's okay and not gonna be scared. The other thing that you got to remember is you've got to talk to the parents and ask them what type of language that they use for things like pee-pee, and you know, I always go in and say, could you tell me the terms you need that you use when they go pee-pee and when they go poo? Okay, because if I go in there and say, do you need to go void? They're going to look at me like I've got 3 heads. But if I know that the parents have told me that they use the word stinky, that when I go in and say, you need to go stinky, he'll know exactly what I'm talking about. So you need to be using those terms, and you'll see that on pediatric as well. Make sure that you communicate with the parents to know what type of terms, because these kids, that makes them nervous if they're not used to hearing words. I mean, I would never go to a child and say, you need to go void. I mean, I probably wouldn't say that to y'all. But, you know, use the terms that they understand. Our older adults, it's a bad thing that most everybody that goes through surgery is some of our older adults. I know Tyler's patient. Of course, do y'all know Tyler got to go to a heart? Okay, just want to let everybody know Tyler got to go to a heart. That patient, when we walked in the door, in the OR, I thought was dead already. Very, very, so immediately what I started thinking was, oh my goodness, he's getting ready to go through this major surgery. And he was only, 70, 81? So he's older. I'm thinking post-op right off the bat. Because I'm thinking he already looks, and I haven't even assessed him, but he was pale, very emancipated, very, very skinny, had no extra fat, and then he's going through you could see his ribs, couldn't you? I'm thinking, oh my goodness, how in the world, if he makes it through this surgery, how am I going to pre-op him? How am I going to get him better? Because I know that with older adults that look with other disease processes have lots of different issues. One of the biggest things is fluid volume and electrolytes. I can tell you that when you are in a pre-op situation, you better be looking at your patient's electrolytes. I know you won't have a situation where you can actually look at the chart during this rotation, but if you know your patient's going to surgery, because there's going to be times that you got to get your patients ready to go to surgery, you better be looking at those lights. Which ones do you think I'm really, really wanting to make sure is okay? Y'all are so smart! My gracious! Everything's potassium. So that's what you just know. It's just always potassium. Because you know it's potassium because we need potassium to make our heart function. Okay. So I need to know that. Do I need to know that they're peeing okay? Yes. Yeah. I need to know that whatever I'm putting in is coming out. What lab values do I look for to make sure kidneys are working?
BUN and creatinine.
Did y'all get tired of me saying that?
No.
All right, the one thing I can tell you, you know the lab values for what you're going to, or you know the labs that you check for different functioning, but you know what I need you to start doing? I need you to know the values. So when I hop off at you, I got a potassium level of 2.9, then you're going to know that it's low, and you need to do something about it, right? Because I need you to start clicking those lab values off like that. If I got a hemoglobin of 8,
Low.
you worried? I'll go ahead and send them to surgery.
No, it's too low.
Is that going to be something that you need to
No.
let somebody know? Exactly. Like this little man, the first thing I thought about was his healing process. I thought, oh, Lord of mercy, how is he going to heal from this with everything going on? Sensory, I can deal with sensory. I don't get too stressed out over patients who have sensory problems. Not so meaning, because there's really, is there anything, I can't make them see better except give them glasses. If they have a hard time of hearing, talk louder, okay? That is a problem that you're going to have to address, but that's something I think is an easy fix. Okay, so yes, I understand that I can't see either. So don't tell me to read anything if I don't have my contacts or my glasses on. We can fix those type of things. That's not going to impede his surgery. Just know that when I give him something to read, then I got to give his glasses or I need to talk loud. Immune function. Why do they have a decreased immune function? Thymus is about gone, isn't it? But, okay, so, why? Well, let me just back up and say this. Why am I even worried about immune function?
Fight infection. You gotta have a high immune function.
Because what is the major problem with a post-op patient? Infection. And I gotta make sure if he's already got a decreased immune function, what do I need to look at post-operatively to help him? What would be one of the biggest things that you think that you would see a physician order for someone? Antibiotics. Prophylactically? Do you think someone that's already got an immune problem would be on continuous antibiotics after? Because sometimes now the research is saying just give them an antibiotic before they go to surgery and you should be okay.
Well, no.
Not with somebody who's already compromised. I need to continue that, don't I? So I need to have a good 7 to 10 days after that. So that needs to be something that you need to be looking at. What lab's going to tell you about their immune function? White blood cells, exactly.
And albumin.
What about, well, they have a CBC and a differential. Which labs would you look at to let me know if he's got an infection?
White blood cells.
CBC with the differential. What does the differential do? Breaks it down into what? There's how many white cells? 5 different kinds.
Never let monkeys
Emphasize.
eat bananas.
All right. How do I know a patient has infection with some of those lab values? I know my group. What's going to happen to those lymphocytes? What's going to happen to the neutrophils? Exactly. Neutrophils go down, lymphocytes go up. That's going to be something that you're going to be looking at to see if they've got an issue with their immune response or they've got infection. Wound healing. Oh my goodness. What type of patients are going to have problems with wound healing?
Diabetic.
Y'all better be glad y'all answered that one right. Yeah. So, what kind of things do I want to do for somebody if I know they're going to have wound healing problems? I heard something. Nutrition. What kind of nutrition? High protein. Exactly. What kind of vitamin do you want to see? C. Vitamin C. Vitamin C and D. Vitamin C is going to be your biggest and your proteins. So once they start eating, you need to know they need to get some vitamin C and some protein. Some patients you might even have to increase their calories. Like patients that Tyler had in the OR, I would love to give him as many calories as I could give him after he wakes up. I would want to give him food plus booze or anything. That little booger needs some calories. Big time. Big time. All right, my liver, I got to look at it because I just gave him, or the anesthesiologist just gave him lots of drugs. So I need to make sure he's got adequate liver function. What is it? ALT and AST? Because when patients have an elevated AST and ALT, can they break down that anesthesia? So what would happen to them, what kind of things would you see if you knew that their liver functions were out of whack and they're trying to come out of surgery? I think you're on the right track, Jeff. They are not going to wake up because what are they doing? They're hanging on to that medicine, aren't they? So they're going to be very difficult to wake up. Is that alarming for people?
Yes.
For nurses? I get alarmed when I'm like, I can't get this person up. I'm screaming, I'm hollering, I'm put cold rags on them, and I can't get them up. And then I'll look over and say, oh my goodness, their liver function tests were elevated. So they may be one. So what? Well, first of all, I can't wake them up. What am I going to look for? Breathing, right? What do you expect the heart rate to be high? I mean, the respirations to be high? They'll start being low because they're going to be so relaxed and they're just going to hang on, especially if they had some morphine. Because you know what morphine does? Decreases respiration. So, it what? I'm worried about breathing. I'm worried about bowels. Are you older? Yeah, I just get tickled because I think I don't know who we were. I think me and somebody was talking about the other day. Every older person is worried about their bowels. They are so worried about their bowels. But I would worry at this point about respirations. We can deal with their bowels later. All right, so you can see that age has a major impact on how I'm going to plan my education, right? I've got to look at lots of different things before I start planning my care as far as pre-op. This is another one, general health, that we're going to look at. I've got to look, and I know everybody hears me preach about smoking. Well, smoking, when I have a patient who smokes, I got to know that when they go to sleep. Because they have a tendency to be a little bit lazy when we put them on the ventilator, and they just don't want to breathe as good for me. So I need to know that for a fact. I also need to know if they have any type of alcohol abuse or use. So there's a reason why you asked them in the pre-op time, do you smoke? How much do you smoke? Do you drink alcohol? And I know every time when I took my husband to get his knee done, they said, do you drink alcohol? And he just looked at me like, should I tell him or not? And I was like, yes, he is a social drinker. Yeah. Well, how many beers do you drink? I was like, don't ask him. I just like, 10 on Friday and Saturdays, okay? But I need to know that. I need to know when they do, because sometimes patients come in and they are addicted, they are alcoholics. I need to know that because they're not going to respond to anesthesia like I would expect them to. In other words, I may need a little bit more to help put them under. Drug addicts are the same way. If I have someone who's addicted to oxys or whatever, I can think, and the anesthesiologist or the nurse anesthetist has done her measurements on the weight, done all that stuff, and she looks and she's like, I can't get this person under. It's because they build up a tolerance, and it takes more. Now, my dad never did drugs. Now, he would smoke them, but he never did drugs, and it took a buttload of drugs to get him under. My best friend that's a CRNA would never put my daddy to sleep because she said the amount of drugs that it takes to put him under scares her. So there are different people. So it gives me a history of letting us know, if they don't respond to what. And I know that one thing that, I know that Amy does this, and you will see it when you're in the OR setting, is when she's getting ready to put them to sleep, she puts all the medication in one syringe, like the Pentothal, Michael Jackson drug. Mm-hmm. Looks like milk. Mm-hmm. She puts the drug that she's going to give them as she's calculated it, and she gives them a test dose. So she just gives them a little bit to see how they're adjusting. Because obviously I would not want to give them a whole lot if I didn't have to. Like with me, you can give me this much and I am out for days. But with my dad, you had to give him the whole syringe before he ever got groggy. So I like that and the way that she does that, because you don't want to give patients medicine if you don't have to. So she gives them a test dose just to see how they're responding, and even though she knows that the whole calculation is going to be given, but she's going to give them and see how they respond first, which I think is really, really, really neat. One of the things we've got to look for, now through some of these, I did sort of stick some interventions in, and those of you that have your PowerPoints, I have a hard time telling you that something's wrong and not giving you the information on what you need to do about it at the same time. I mean, that's just me. Because I want to know, well, you tell me this is wrong, but I need to know what I need to do. So I've sort of put some of the interventions after some of these, and I hope it's not confusing, but I just try to give you this. I know that I've got to watch my patients who have alcohol problems for alcohol withdrawals. Have you ever seen anyone in DTs? It is very, very disturbing. And it's very, very scary.
It's potentially fatal.
And it's potentially fatal for that patient. So if I know that I've got an alcoholic, you can bet your bottom dollar that I'm going to have the emergency equipment readily available in case something happens. What is DT?
Delirious tremors.
Say it louder, Maddie.
Delirium.
Delirium tremors.
Say it loud, say it loud.
Delirium tremors. I'm sorry. I mean that I take for granted that y'all know things like that, and I appreciate you telling me I don't know what it is. It's delirium tremors, and it is like the patient is shaking, uncontrollable, and it's just I don't even know how to. Can somebody help me describe it?
It's like a continuous seizure.
It's like a seizure. And you worry about what? Safety, but you also worry about
Heart rate, breathing.
airway. Exactly. You worry about their airway. Because what happens when a patient sneezes? Don't you worry about their airway? So same thing with these they're tremors out of control. I mean, it is very, bashing out and, oh, it's just scary, guys. Scary, scary, scary. So if I know someone is a potential for that, there are medications that you can give that patient. In other words, if I was the nurse anesthetist and I knew that my patient was an alcoholic, I would make my adjustment of the medications that I gave. Ask me what they are, I do not know. But I know that they would maybe not give them certain things because it would potentiate the alcohol.
I had a patient who had, she was an alcoholic, and so they had something I think give her that she was taking for DTs. I don't remember what it was now. But it was, she didn't drink a lot. She admitted that. But there's a kind of medication they were giving her because she had already started experiencing that.
And antidotes. There is some that you can give that will. Yeah. And there's some patients that you will even see that they know that they're alcoholics, and that the doctors will order beer for you to drink at night. Yes. Yeah.
That happens.
Yeah. Give me a beer. I told y'all about the OB patient that I had that all she craved was a beer the whole time she was pregnant. No. Yeah, all she craved the whole time she was pregnant was the beer. She said, I hadn't had one, so after she delivered, she was telling me about it, and I looked at her husband and I said, it looks like you need to go to the grocery store. So he went and got her beer, and I let her drink her beer, and she's such a cool person.
At least you waited to act.
Exactly. At least I said, then we'll just pump your breast, and then after you drink the beer, and then we won't give it to them. So anyway, as far as patients who drink alcohol, you know they're probably not getting what? Good nutrition. So because they're going to rather have their beer than their food. So you know these are the ones that with a decreased nutritional status, you know that after post-operatively they're going to need food and they're going to need supplements, because not only because they're not malnourished, but because we need what to help him get better. We need proteins and we need vitamin C. So it's not just to help him gain some weight, it's to help because he's had an incision that he has got to help get better. Malnourishment, I just talked about that. We know that the patients who have decreased nutrition will also have trouble with wound healing, plus they don't have a lot of energy. Most people who go through surgery don't really have a lot of energy after it, but what do we have to do for them? Get them up. I know you're tired, I know you're hurting, but I need you to get up. Okay, so I've got to make sure that I give them lots of calories, lots of protein, lots of vitamin C. There may even be a point, and I keep going back. I've had Tyler's patient on my mind. I just cannot get this little man off my mind. But I think about him, he would probably be a candidate for TPN. Do you know what TPN is?
Yeah.
Total nutrition. So that would be one that, because that's full of what? Sugar.
Yes.
Full of sugar, full of vitamins. I mean, that is really going to put some major nourishments in him. So I think you may even see that with a patient who's malnourished. Obesity. Our patients that are obese are at high risk for pneumonia. They also have problems with wound healing. So we need to make sure that we keep an eye on that wound. Let me just ask you, when I keep talking about a wound, what kind of things do you look for when you're looking at a wound?
Drainage.
What's the acronym?
You ever heard of Rita?
Rita. Yeah, Rita.
Redness?
Yeah.
Edema? Drainage?
Exudate.
Redness, edema, erythema, drainage, approximation. Do you know what approximation is? It is close. Good. Those, I need to see that when you assess Rita, when you have a wound, I need you to be assessing Rita every time you look at it. Knowing that patients that are obese have problems with pneumonia, what are you going to be doing? Do you think I'm picking when I say turn, cough, and deep breathe? Do y'all get tired of me saying that? Okay, because I'm telling you guys, when we take care of patients that are post-op, I do not want them to get pneumonia. I do not want them to get pneumonia, so you've got to do it. Going backwards. All right, when we look, and I went through each one, like I did a cardiovascular, things that they're at risk for, and I think a lot of this stuff I've pounded in your brain as much as I can pound in your brain. You know that when they lose blood volume, are they being loud? Are they louder than me? You know that when they go to surgery, they're going to be at risk for blood loss, correct? Okay. So we know that we've got to worry about replacement of that. If we don't, then they could, when they hemorrhage, they could go into shock. Exactly. So who's going to be catching that? First of all, what makes a patient go into shock? Decreased volume. Does it matter at what rate?
No.
The faster they lose it, though, the faster they're going to go, right? But you may see a patient in surgery that loses a little bit of blood, and it's like it's increasing, so it may be every 2 hours that they're looking. Now, the point I'm trying to get at is when we look at blood volume loss, we also look at the time frame that they're losing, because obviously more critical if they lose it all at one time, as opposed to losing it slowly. The good thing with slowly is, can I replace it slowly? So if it's lost quickly, I need to replace it quickly. If it's lost slowly, I need to replace slowly. So you look at the total blood loss, and as they're losing, that's why the nurse anesthetist, when that patient's losing the blood in the surgery, she is constantly looking at that suctioning machine that has the amount of blood loss. Because if she sees it start going up, then she knows right then, I need to start replacing more. Okay? Because the bad thing that happens a lot of time with all the history of the patient, if they've already got cardiovascular problems and they're having blood loss, do I want to quickly fill them with a bunch of fluid? Because they're going to go into fluid overload, and then we're going to have more problems.
The estrogen too, she had to take into account, because a lot of that in that canister was violent. I mean, there's a lot. Yes, there's a lot here, but, there's drops that which is what they're doing too.
Exactly. Because she's saying that with her surgery, there was when you looked at the canister, it was a fairly large amount in there, but some of it was vial. So it wasn't like, it was the whole thing of blood loss.
Well, they were irrigating too.
Yeah, and if they should be saying, how much irrigation did you use? They should be looking to see how much irrigation that you used, so they can subtract that. But I can tell you, in an emergency situation, who had the bleed out? Kayla? you had the bleed out in Jade, didn't you, the other day? I'm sure that at that point, because that patient was bleeding very quickly, they were not worried about the irrigation. They were worried about getting blood, and I know they gave four units. Okay, so at that point in time, they were not going, okay, I'm going to subtract this irrigation. This much went in. Not when you're needing to replace that way. How fast did they give it? Most of the time, when you're on the floor and you've got to give blood, how many hours do you usually give one unit?
4 hours.
4 hours. It usually takes a good 4 hours to administer a whole pint of blood. Yeah. So it's really, really neat to actually see them giving it and replacing it and that kind of stuff, and that comes with time. But you just need to know at this time it needs to be replaced. Okay, I did you a couple of little interventions there. Pulmonary. This is one of the major reasons why I need to know that if my patient smokes or not. Most people, you know what happens when you actually take in a cigarette. It decreases your CO2 and all that good stuff. But one of the major reasons, and it is called, once you are smoking, you start having a increased level of carboxyhemoglobin. Carboxyhemoglobin. Smokers increase that level. So as they increase this hemoglobin in the bloodstream, it is taking up space, an empty space, for the hemoglobin that has the oxygen to carry it to the vital organs. So in other words, you know how the little hemoglobin has the oxygen and it goes around. These are little people inside there that don't have no O2. So in other words, they're just standing there not doing anything, taking up space, and they're getting in the way of my other little men that are trying to have their oxygen going to where they need to go. They're just in the way. Okay? Empty space. The levels will decrease as you get. But when you're worried about the damage that's done, you won't regenerate that for years. Okay? It takes a long time to regenerate. I think the research was saying 5 years. After you quit smoking for 5 years, you begin to start regenerating some of the functioning. But just like you learn with COPD, when that tissue's dead, it's dead, and there's no regeneration. So there's a reason why you want to ask these people if they're smoking or not, because you know if they do, then they have a decreased perfusion. So I need to be aware of that, because they may start dropping their O2 sats on me. So I can give them some O2, give them more O2, do whatever I need to do to make sure that they maintain perfusion. I'll go over just this one more and then I'll go get your test. The other thing that happens with smokers is it decreases. If you know those little finger-like little things, the cilia, I just love those. I just think, oh my gosh, I got these little finger-like things that are going in my little airway thing, and they're just helping me get rid of snot and all that kind of good stuff. But sometimes, ours are going like this. Smokers have a tendency to go
Slowly. They're tripping.
like this. And so it doesn't help. The cilia is not aiding my patient in getting rid of junk that I've got, things that I breathe in every day. My cilia works so fast, and it's like, if I took a deep breath and there was something in there and I inhaled it, and my cilia would go, woo, I don't like that, and they'll get rid of it. But smokers have a tendency to not, and they'll just have that, whatever we inhaled, just sticking there. So, of course, I know they're going to be at higher risk for pneumonia. The other thing that they're at higher risk is atelectasis. Atelectasis. Have you ever heard of that term before? And what happens with that is the actual alveoli collapse. So if they're collapsing, there is no gas exchange. Okay? So you know with a shadow of a doubt, you've got to get somebody who's smoking up and going. Okay? They have got to. Does that mean everybody that smokes that goes through surgery is going to have pneumonia and atelectasis? No. No. You know why? If they're my patient, they won't. You know why? That's right. No more laying around. We're getting up. We are deep breathing. We are doing it. You guys, please, I can't tell you enough. Be that advocate. Be that person. I get so tired. I was telling there, I get so tired. And I guess because my daddy smoked, and every time I took my daddy in, they immediately said, "Oh, you're a smoker?" I'm like, no, he's a person. He's a person who likes to do this. So you know what? That's a risk factor. I'm going to treat him, and I'm going to do whatever I can to help him get better. Y'all going to get on my little high horse. But I get agitated because just because he smokes doesn't mean I'm not going to take care of it. He has high blood pressure. Does that mean I'm not going to work? It's a risk factor. So I know he has high blood pressure. So what am I going to do? Interventions to help decrease that blood pressure. I know he smokes. You can bet your bottom dollar I'm going to be doing lots and lots of. And I may even start beating on my patient's chest before they ever realize it. I mean, not beating, but doing some chest percussion because I know they're at risk for that. It's every disease process with diabetes. Don't you know they're at risk for having problems with their wound? So by golly, it is my responsibility to make sure I do everything I can to decrease my patient's risk of having that problem. That makes sense? So, turn, cough, deep breathe. Smoker or not smoker. All right.